Hello everyone. I am Dr. Vaishnavi Pradhan from the team of Voice of Healthcare, and I'm delighted to welcome you all to our special series Diabetes 360 Degree Shaping the Future of Diabetes Care, created exclusively to mark World Diabetes Day 2025. This series brings together leading voices from the world of endocrinology, public health, digital innovation, and policy to spotlight where India stands today and where we must move in the future in our fight against diabetes. India is witnessing one of the fastest growing diabetes burden in the world. We are not only seeing an increase in overall numbers, but also shifting patterns, younger onset, wider urban rural gaps, rising prediabetes, lifestyle driven risks, and growing comorbidities. Despite better treatment tools and medical technologies, gaps remain in early detection, continuity of care, awareness, nutrition literacy, mental health group, and workplace health systems. Through this series, we hope to explore how India can adopt a holistic 360-degree approach to diabetes prevention and care. To help us deepen this conversation, I am honored to welcome Dr. Bansi Saboo, Regional Chair, Southeast Asia International Diabetes Federation, and Chairman DiaCare, Diabetes Care and Hormone Clinic. It's truly an honor to welcome you, sir. Welcome to the session.
Hello, thank you.
So to begin with, sir, let's begin our discussion with a very brief topic, which is how can India adapt the international best practices or global diabetes framework to strengthen its own national strategy for prevention, access, and outcomes.
So, first of all, thanks VOH Healthcare, Dr. Vaishnavi, for this wonderful program of Diabetes 360 Degree, shaping the future of diabetes care, particularly from India and Southeast Asia. I am Dr. Bansi Saboo. Currently, I am Chair of International Diabetic Federation, Southeast Asia region, sitting in the board of International Diabetic Federation, and I am also heading Diabetes India. And you are very rightly asked the first question that how the global good practice which can really change the way we are practicing. To be very frank, I must tell you, and we should feel proud that we are having one of the best practice in the world as far as emergency is concerned, as far as availability of medicine is concerned, access to these medicines at a much cost effective. We are proud to have these medicines at a very, very cost effective. As we are proudly, we can say like you are doing a program and reaching out to millions of people. These type of facilities and things are not available in other parts of the world. We always try to compare sometime with some American countries or some European countries, but still we are available throughout the day 24 by 7. Our doctors are really working very hard. But yes, at many parts, because our auditing is not there, we don't have that system, and our population ratio is also very, in compared to the doctors. That's again a challenge. So what we can learn from them is the data, properly keeping the data. Our follow-up is poor. Our data publication is poor, and that we have to learn. If you just see that we publish real-world data in a very different way, while their publications are completely different. So that's the reason. While our research is not supported because we clinicians are very busy in clinical practice. That's a again a challenge. The same clinician should do the research. If having a 2 days in a week a clinic and 2 days in a week, if they are given a choice of a research, then data publication will be huge because they know the clinical practice and they know the patients also. So there's a lot of scope of improvement. I don't say that, but I'm not saying at the same time that we are not working the way international world is working in field of diabetes. We are using the same molecule which is available in the world. Rather, at there the price is very high in compared to we are at a much lesser price. Recently, SGLT2 inhibitor before 2 years was off patent in India and it is available in 10 cent or 5 cent in compared to while it is $4 or $5 or €4 or €5 to €8 in European and US market. Every patient even they can't afford to give it. While here we are giving to almost everyone. Recently now, the semaglutide, which will be off patent, but the older GLP-1 is already liraglutide off patent, and which is available at cheaper price also. So the only thing is we don't have the auditing, we don't have the review process, we don't have our clinicians working in research, we are not publishing the data, and some of these things we can get the best practice from European or US, some of the developed country, to publish our own data. And if there can be support system from the government and the ecosystem can be improved, I'm sure we will have a better care in compared to what.
Correct. So yes, very rightly pointed out. Data has always been our pain point because we definitely need some digital adaptation also in order to maintain these data and have to have these directories. So,
Very
going forward, my next question is that diabetes control require more than just healthcare interventions. So, how can stronger collaboration between sectors such as health, education, labor, and corporate affairs help build a more holistic national response?
So this is very rightly said, Vaishnavi, that one is that awareness itself. And a lot of myths are there. That in complete ecosystem, even just by giving in healthcare or a medication, the patients are not compliant, people are not compliant for diet and exercise. Your system is not like that. And so many times they keep on stopping the medication for a chronic disease. That's a challenge for them. And that requires a very strong ecosystem where you are seeing the corporate or the government system or the public health system will also work to improve the care. And that's the reason two-thirds of our diabetic patients are actually not achieving a tight control. One of the important reason is this. Even with so many newer medication, and the access and accessibility of these doctors is also there, but still we are not able to achieve a tight control, and a lot of patients are developing complication. One of the important link which we are missing is this. Yes, definitely we can work on it, and we are working already. Different organizations are working together and try to build a ecosystem where everyone can contribute and can get a better outcome for our patients with diabetes.
So, would including diabetes screening and management within the occupational health standard make a significant difference?
So yes, we have published on paper that even below the age of 25, in Defeat Diabetes campaign, we found a lot of new young people are developing diabetes. While India still have above the age of 30, people should be screened for the sugar, and even US it is more than 35. As Indians are more prone to develop diabetes, even in younger age type 2 diabetes. So definitely in occupation at every level, there should be opportunity to screen these people. It's not just for sugar screening, rather, we should try to find out the risk factor for developing diabetes. And they should be also screened and we should be modified. So, even your sugar may be normal, but you are at the risk of developing diabetes. So, there should be some modification, risk modification at that level. When we go in private corporate sector to teach and educate, like today was the this time the World Diabetes Day theme was a well-being at a diabetes of person at a workplace. So we have done and created a lot of activities in last couple of weeks, from 1st November to 14th November, and we try to explain them. There should be enough space for doing a lot of exercise or creating a awareness where healthy diet can be in afternoon time, or there can be more proteins, or gym can be there in bigger offices, something like that. So many things can be done at office level also, and they should not have any taboo to tell everyone that I am a person with diabetes. That should not be there, and they should not be having a stigma of showing that they are the person with diabetes. So these are some of the things which can definitely improve the care for these people, and early screening will definitely help them for early diagnosis, aggressive management, and complication will be prevented.
Correct. So, primary care is often the first point of contact for most of the people. So, what improvements or policy shifts need to be made to have early detection, diagnosis, and follow up of diabetes
So
patients?
primary care level at NCD aligns at a national level in a government program of a prevention of diabetes. There's a definitely even at the ASHA worker level now the screening program is been started by the government of India, and these people who are detected with high sugar they are referred at a CSC or PSC level also, and we have created a system of educating these people also. And there are modules by ICMR, by Government of India, and plus private organizations like Diabetes India and RSSDI to educate. We have created one program with Public Health Foundation of India with Dr. Mohan's Academy and national and one of the experts. We created a modules to educate thousands of doctors. And in this diabetes, we have created 25,000 doctors and a national diabetic educator program. More than 10,000 educators we have created them to know about the early diagnosis and early and aggressive treatment, managing them, and for better management and preventing complications. So definitely, lot of work is going on, but still it is not enough. As you know, that's a large country and a lot of people with diabetes and a lot of lay people. So with a lot of myths also. So that's what we are doing.
So we have so many public health programs. Is it possible to have like pre-diabetic screening and lifestyle interventions which could bring down or maybe
Lifestyle
help in our
modification and pre-diabetes screening program is there, but it's really difficult. Sometime and then to patient to accept that. Suppose somebody comes with a random sugar of 116, you are saying them it's a pre-diabetic, but that's to be again confirmed, reconfirmed two times, either by the OGTT or by HbA1c. And then to teach and educate that patient, it's very difficult because non-compliance for diet and exercise is more in compared to medicine. So that's a difficulty, but yes, still the policy is there and we are trying our very best for it.
correct. And also, we are seeing a rising
Yes.
number of working age individual living with diabetes. What practical steps can organizations take to promote better screening, nutrition, and physical activity at workplace? Since the theme this year is around workplace, so
As I
if you
told you
can
very
highlight that.
rightly, Vaishnavi, that younger and younger people are there with the diabetes, more persons who are at workplace having diabetes. Now, if you go to any place where you will find 30%, one third to one fourth of them are having already high sugar. So, educating them in a complete system to create, and then to mainly in a healthy, nutritious diet to be given. People should take more fruits, nuts, sprouts, buttermilk, dal, all these are to be consumed more in compared to a simple carbs, which is very commonly, either bataka vada or aloo vada or poya or paratha. And these are very common food items which we have to replace with a healthy item. So it's really difficult. Nutritionists is going, educators is going, but a lot of work which we are doing through organization and creating a lot of awareness about this. That particularly the protein diet, we always ask that whenever you see a plate of food, first thing you ask yourself, where is my protein, and you start with that. So that is what I always tell that in Gujarat, Rajasthan, and we always say dal roti ke liye ji rahe hain, dal roti kamani hai. So our ancestors were also so smart. They always tell dal roti. They never say roti dal. So it means dal is more important than roti. It means the pulses which are more important than the normally we ask them to take more dal in compared to dhan. So this is what they have to learn, but it requires a lot of education because other side they have already an idea of taking food in last 25, 30 years, and one education program will not change completely. But it's a constant endeavor which we are doing through education, online education, social media, physical program, face to face, and plus those who are coming to our clinic, we also try to teach the persons with diabetes and their relatives also. So some impact is going on, but still, I can tell it's very little impact is going on.
Correct. It is a very right takeaway message, I mean, from this session and our discussion that we have to take care of what we are eating and what's there on the plate before having it. So, asking you about the changing landscape of the diabetes altogether, especially with younger onset, lifestyle pattern, and comorbidity. How are these trends reshaping the treatment approaches that you have in
The
clinical practice?
treatment approach is one is with the younger population, we want it to be more aggressive. While the problem is the young population, they don't want to go to the doctor because they are so busy. Their temperament is different. They don't want to waste the time at the doctor's clinic. They are not worried of starting with the diabetes. That's a non-asymptomatic disease. When they develop complication, then they realize. By that time is gone. Already 10, 15 years of your life, you have, was having uncontrolled diabetes, and now you have a complication. So that type of education constantly we are working. But yes, there is a younger population. As a doctors or an organization, we want a more aggressive control for them. While as a patient perspective, they feel that they don't are going to develop any complications. They are not looking for aggressive management. So that's a big difference. But yes, education will help. Sometimes we get them in our clinic, sometimes only in mass education, sometimes through social media they get educated, and then they come back. And they also have a lot of myths also that uh, sometimes they develop complication only straight. But yes, for aggressive management is required for younger population.
So, if I may ask, that where do you see the biggest gap in the continuity of care, and how can how can these be addressed to improve like long-term outcomes?
So one is follow up and other is monitoring. So people don't want to check the sugar yesterday. I'm sure you must have realized in some time. Because they don't want to check. They feel that if I will be checking, my family, everybody will ask me why sugar is high. They keep on taking, but they don't want to monitor. If somebody monitors, then I'm sure he will take action also. Monitoring is always followed by action. If I have seen my sugar is 300, then definitely I will like to go to doctor, or at least I will call him. But if I'm not seeing that it is 300 or 250, I'm hardly bothered to that. So we have the biggest gap is the follow-up and monitoring, which we don't want to do. That's the Indian tendency. As other problem is the medicines are available in India almost over the counter, which is ideally not to be done, because a one prescription is not valid more than 6 months, but people keep on taking the medicine. They don't want to go to the doctor, so they keep on taking. And medicines are also available and they get it also. That is also a wrong practice. That's the biggest gap, because then they are not taking properly. In between, their sugars are uncontrolled. They have some problem also. So these are the some of the challenges which are to be addressed. Definitely, we talk about all these issues, and the answer is not simple. It's not like overnight you can change the thing, but still, yes, we are keep on trying.
So beyond medication, diabetes brings like a lot of emotional and behavioral challenges. There are a lot of restrictions. So how can these be addressed, and how can these issue of stigma, mental fatigue, and treatment burnout among patients be removed or addressed?
So it is like a sort of a diabetes distress. They have both sides. They have a, you will say that they have already taboo. They don't want to tell anyone. They don't want to change their habit. That's the also reason they don't want to tell. Sometimes I don't want to tell at workplace that please get me sugar free tea, and I don't want a tea without sugar, because everybody will know about it. And the other thing may be that I like to have that tea because at home I'm not getting, because my wife will not give me. So there may be multiple reasons, and then that's the reason he doesn't want to tell anyone that he is having this issue. So we try to address this issue. That's in between. You can say this is a distress in sort of a. He does not want to take insulin at workplace. He does not want to take tablet at workplace. He does not want to tell anybody that he is not a diabetic. He wants to eat actually all sweet thing at office only, because nobody knows in the office that he is having this. So there are a lot of issues. But yes, emotional issues are also sometimes more. Many of them are a lot of mental stress. Doctors are constantly trying to counsel them, and we become, like for them a counselor and reassure them. And many times they come out of it, and then the stress goes significantly down, and the sugar also get better.
Correct. So, since we were talking about that, monitoring is still a challenge. So, we now have digital health solutions, wearables, and AI tools transforming diabetes management.
Only challenge is the
Uh,
cost, because 5,000 rupees is a roughly cost for continuous glucose monitoring. I can monitor all my patients on a digitally monitor, and maybe at any parts of the world they may be staying, and still I can digitally monitor them through the continuous glucose monitoring. And we have a system, but the problem is the cost, because a continuous monitoring mean roughly almost like 1,20,000 rupees is they have to pay, or because every sensor is costing them around 5,000 rupees plus minus 500 rupees. So that's a challenge, but some patients they agree, some 99% they don't take any of the cost.
I mean, how authentic it is, and how credible things are, if you can help us understand that.
So you are talking of how credible.
The readings are, I mean, these
Oh,
devices that
yes,
we
I mean, these
have,
continuous glucose monitoring, some of them are very, very good. I mean, they are the world leader and they are available with us. I don't want to name the companies because of the conflict
yeah,
of interest will show, but there are other companies also which are from other developing countries, from Asian countries also. We have continuous glucose monitoring and they are also reasonably good. So they are credible monitoring devices which can digitally or we can connect with our patient and instantly we can monitor them.
so, I mean, as India aims to curb down the growing diabetes burden, what kind of indicators or data systems do we need to truly measure and get into our system to understand the impact and
One is the
ensure?
continuous glucose monitoring. The other wearable device, their lipid profiles, their blood pressure, their BMI, the weight monitoring is the most important thing, and the risk score for fatty liver and heart disease all are to be calculated and that should be monitored regularly. But the diet and exercise is also very important. Now, most of the devices which we are using in the phone, they also gives you a lot of information related to exercise, sleep pattern, and even diet also.
Correct. So, and how can we link the national health targets that we have and with corporate wellness and community level outcomes for a unified
That
approach?
will take Vaishnavi some time because government is trying, but I think it is still in a very nascent stage because they are primarily looking for a persons with diabetes or obesity or with heart disease and cancer is the major challenge for the government of India as far as the NCD alliance is concerned. But in future, these will be aligned with the national government portal, and probably that will help.
So, I mean, since you have made out time and joined our session, what is that takeaway home message that you want to give to our viewers who are watching us live?
So one is on this World Diabetes Day. One, at the office place of the diabetes should have less and less distress. How we can educate the people, and it's like if I'm a person with diabetes and I'm maintaining my good sugar, good control, having regular exercise, I can be the brand ambassador for the same and should give the same message to other 10 people as far as diet is concerned, exercise is concerned, regular monitoring is concerned, follow up is concerned, weight reduction and weight management is concerned. That should be the way how it can be because a person with all these things, if he is doing but he is not telling other colleagues and other friends that even I have a diabetes and maintaining everything, it is of no use. It's your social duty that you tell other people to get them motivated. If you are doing good, they should be also doing. Everyone should have a better outcome. That is what we are looking for and preventing the complications.
So, thank you so much, sir, for your valuable insights and helping us understand the path ahead with such clarity. And to everybody listening, thank you for joining us this episode of Diabetes 360 Degree and listening to us and understanding that what are the steps for going ahead. So, thank you so much for making out time, sir, and thank you so much for joining the session.
Thank you.
Thank you. Bye.